Okay, committee, let's come to order. Welcome to Health and Human Services. First item on the agenda is a request for bill introductions. Representative Pickert.
Thank you, Mr. Vice Chair and members of the committee. I'm Sandy Pickert, State Representative, and I'm introducing bill number RS 2550 on behalf of myself, and there'll be other sponsors. But this is an act concerning health professions and practices related to the Kansas State Board of Nursing, powers, duties, and responsibilities, requiring all board actions related to non-practice violations be void, allowing for late license renewal for professional, practical, and advanced practice registered nurses, setting fees for late license renewal, limiting unprofessional conduct to acts related to the practice of nursing, prohibiting the board from taking retaliatory action against a licensee based on unlawful acts made against the board and creating a cause of action for violation of such prohibition, requiring board members to be subject to Senate confirmation, requiring the board to issue refunds for overpayment or duplicate payments, and amending several current statutes. Are there any questions?
Any questions from the committee? Seeing none, the bill is accepted. Thank you.
Thank you so very much.
Oh, 1 minute. Representative McDonald? Yes.
I have another bill, that's all.
Okay.
Oh.
Thank you very much. Are there any other bill introductions today? Representative McDonald.
Thank you, Mr. Chair. I have 26 RS 2831. It's an act concerning health and health care relating to personal needs allowances, increasing the personal needs allowance for residents receiving long-term care in a Medicare-approved nursing facility, and repealing the existing condition, basically $50 to $85.
Very good. Committee, are there any questions? Oh, it's on behalf of who, Representative McDonald?
Myself.
Okay. Any questions for Representative McDonald? Seeing none,
Thank you.
the bill is accepted as introduced. Thank you. Any other bill introductions today? Seeing none, we will go ahead and start with our presentation today. We have Mr. Stephen Anderson from Office of Medicaid Inspector General to give a report. Mr. Anderson.
Mr. Chairman, members of the committee, I am Steve Anderson. I'm happy to be here today to talk about the Office of Inspector General. Should have my presentation there, but I'm going to hit some of the highlights and be happy to answer questions at any point along the way since it's a fairly long presentation. I just wanted to point out that our statute that created the Inspector General's office was expanded by House Bill 2217 that was effective July the 1st of 2025. It expanded our responsibility to include all Kansas cash, food, and health assistance programs. It also included a fiscal note that would add 9 FTEs or full-time equivalents to facilitate our planned work involving assuming audit and criminal investigations of the cash and food assistance programs. However, due to funding for that bill being delayed, we have not been able to hire those people as we stand here today. I have included a chart that includes all of our audit reports we've completed since 2021. You can also go to the link that's there, it's provided, and you can get to any of our audits, our issue briefs, as well as our annual report. I want to talk a little bit about some of the ongoing audits that we have. We're currently doing an audit of the DCF and KDHE data sharing. And what that is, we're looking at data that both the Defense or Department of Children and Families, as well as Medicaid have, and we're looking primarily at the SNAP data and seeing if there's differences in the eligibility criteria and how that's viewed by the two agencies to determine eligibility. We know from our work on some investigations we've had that people will provide different eligibility information to SNAP and the Medicaid people that's vastly different. And because of that, they end up being eligible for both programs when they may not have been eligible for one of them. And we're also seeing that now in the child care arena. We have an individual that we just were looking at that was getting child care subsidies because she had a job. But then on the Medicaid side, she said she had no job. And both things cannot be true. So that kind of creates those kind of issues. So we're looking at those issues just to see what the circumstances are, but a lot of it we see with the SNAP and Medicaid information. We're also looking at the pregnant woman program, and we're wanting to make sure that people that are rightfully on the program, we're wanting to make sure that they get, if people, once their pregnancy ends and they go through their postpartum coverage, that they get transferred to the correct program if it's applicable. Unfortunately, in looking at this, we found that there are a number of women that are age 45 and older that are actually not pregnant and apparently are on the program fraudulently. In fact, we found 62 people so far that appear to be fraudulently on the Medicaid or on the pregnant woman program that are 45 and older. And we determined that in part because there are absolutely no claims at all for the pregnancy. 45 and older is certainly considered a high-risk pregnancy. And in fact, 35 and older is considered a geriatric pregnancy, so we looked at the 45 and older. And to have 0 health checks is troubling. And especially with that. And Kansas has a higher infant mortality rate than we'd like to see. Last year, coverage was provided for doulas to help with pregnancies to help bring that infant mortality rate down. And so we thought we would take a look at it, and we got our investigative department look at that. And we found with that, those 62, it's the capitation cost for that is almost $800,000 in capitation payments that have gone out for people who appear to be fraudulently on Medicaid. And you have to understand, too, that if you get on Medicaid coverage for a pregnant woman, you're on it for a lengthy period of time because you're over the period of the pregnancy plus the 1-year postpartum coverage as well. So it's an extended period of eligibility. It also makes you eligible for more SNAP, WIC, TANF, food assistance, or I'm sorry, not food assistance, but assistance with your electricity bill and other programs made available to you because of that coverage. So we are planning on opening criminal investigations on not all of those, but we're picking out the worst ones, and we'll be doing criminal investigations on those as staffing allows us to do. I don't know if there's questions, if you want me to stop for questions.
It'd be a good place to stop. Representative Oropeza.
Thank you, Mr. Chair, and thank you for being here. On your, when you mentioned the 62 women, were those rural persons?
No, actually, a lot of them are in places like Wichita and in Wyandotte County.
Okay, so there is like options for health care.
You bet.
For
Yeah,
GYN care.
Yeah, they're not in a what we call a desert area for coverage, or where they do have options, or where there's medical facilities readily available.
Okay, thank you. Thank you, Mr. Chair.
Thank you. Representative Meyer.
Thank you, Mr. Chair. Thank you for being here, Steve. When you were explaining the fraud in the pregnant women Medicaid, can you tell me, was that fraud, or was that application errors, because the applications can be complex, or was it more like administrative errors? Because I heard, and I think yesterday there were some administrative errors happening in the DCF and everything like that. Could you clarify a little bit more other than using the broad term of fraud?
You bet. Yeah, those 62 are, we feel very confident they're fraud. We did see other instances. There were 151 people that are 45 and older that are on the pregnant woman coverage right now. There is a percentage of them that are due to agency error or to just accidental error on the part of the person applying, but not the 62. There are other people that would fall under agency error or individual error. And you're exactly on point, is if it's an error on the part of the person filling it out, then that's not something we're looking to pursue, because people do make mistakes.
Yes, go ahead.
Thank you, Mr. Chair. Just to follow up a little bit on that too, how is it that you determined that these individuals had committed fraud? It seems like a complicated process to determine if a 45-year-old or something like that wasn't truly pregnant. How do you go about that as an office?
Sure. One of the things we do is we request medical records to see if they're, we're able to tell by their claims data, the 0 claims. We can also, and we've had a few cases where we've contacted their doctor to see if they actually saw the doctor confirming it, and there's no visit with the doctor, or if there was, there's actually were pregnancy tests that came back negative, showing they had actually seen the doctor and were told, no, you're not pregnant, but yet they contacted Medicaid and said, I'm pregnant. So those are pretty clear-cut examples there. We had outside of this, we had a case where an individual provided a forged letter from a doctor saying they were pregnant when in fact they were not. So those are partially how we determine that. Does that answer your question? Okay, thank you.
Thank you. Just a little follow-up on that. Way back in the day when I used to take care of pregnant ladies, there was a requirement at the time for proof of pregnancy, but apparently for some time now there's been no requirement for proof of pregnancy. Is that a federal issue, or is that something statutorily we could require? What would you say?
Thank you, sir. That's a great question. That is actually under CMS guidelines, which is Center for Medicare and Medicaid Services. State agencies like Kansas are required to accept self-attestation, which means that if you say you're pregnant, you're pregnant. There is a proviso in the regulation that says if you have information to the contrary, you can require further information from the individual. And that is one of the reasons we looked at the 45 and older, because we would think that an eligibility worker might be dubious if somebody said that they were that old and pregnant, because we had some all the way up to age 60 that were reporting pregnant. It happens, and it legitimately does happen, but it shouldn't be the norm. It's the exception to the rule. But we found that the eligibility workers are not ever following up on that issue of asking for additional information from the person. So, but yeah, CMS says you have to take the person's word for it unless you have information to the contrary. But unfortunately, KDHE's eligibility people are not asking further questions.
Thank you, Representative McDonald.
Thank you, Mr. Chair, and thank you, Inspector, for being here today. I appreciate you giving us an update and standing for questions. I was just looking at your testimony. I'm trying to flip back and forth page to page on your chart to make sure I'm seeing things right. I know last year when you were here, you pretty much assured some of us who had concerns about like going after individuals or taking food from hungry children, if you will. I'm glad to see that there are some larger attempts here on your part to find bigger examples of fraud or waste. But one thing that caught my mind, or my eye, it says school reimbursements, and there's some really big numbers there. Can you give us a little bit more information? How do you determine waste, savings, that sort of thing?
Sure. And you're talking about the school reimbursement audit that we did?
Yes.
Yeah, the $83 million is made up of capitation payments that were made to the MCOs on behalf of students that were receiving services. And that was money that should have been paid by the MCO to the schools, and instead we were paying the schools under fee for service, and then the MCOs were collecting their money, and they were the ones supposed to be paying for the services. Instead, we were paying for it, but yet they were collecting their capitation payments for those same kids. So they were basically a dual payment.
Okay, I'll look that up on your website. Thank you.
You bet.
And Representative Carpenter.
So, is there a solution?
One of the solutions to, and we're back to the pregnant woman issue.
Yes,
sir. One of the solutions would be is to have retraining for the eligibility workers when you have a situation that doesn't seem to fit well, asking for proof of pregnancy. As like I said, they're allowed to ask if it doesn't, if it seems like it's an issue, they can ask for additional information. And I think there had been a suggestion I'd received that we could put something in saying that the person maybe should have to have a pregnancy check or something, or have a doctor's visit at some point, maybe within the first trimester or second trimester. As we want pregnant women to see the doctor. We want them to get appropriate prenatal care. We want to bring down that infant mortality rate. And if you're pregnant and you're not seeing the doctor at all under Medicaid, it's free. You should be seeing that. And I think anybody would agree that it's just a good idea to get those health checks. And you know, my daughter-in-law just had a baby, and she saw the doctor at least on a monthly basis, and she was a young woman. And for a woman who's considered a geriatric pregnancy to not go at all is really hard to understand. So requiring a check at some point seems like it'd be a reasonable step.
I was thinking more about a proviso or an amendment or something like that. So to solve the problem. And I supported this, and I still support it. I think it's great. I never in my wildest dreams imagined that people would take advantage of being a pregnant woman, but I'm looking at more definitive than training. So if you'll bear with me, maybe afterwards or something, maybe we can put a proviso in the budget or something to get this corrected.
Thank you.
Representative Weichel.
Thank you, Mr. Chairman. I'm just thinking about a little bit of perspective here. I think there's just rough math, not perfect, but rough. We have about 30,000 live births in Kansas every year. Medicaid pays for about a third of those, 30% to a third. So we're talking about 10,000 pregnancy and births that Medicaid covers every year. We're talking about 62 cases here. So we're talking about 0.0062%. And I totally agree with you that we want women who are pregnant to be seeking prenatal care. And I'm a little concerned that this conversation might give women the idea that the state is combing through their medical records during their pregnancies. Is that a valid concern?
No, it's not. Like I said, we are not looking at the 18 to 45-year-old or 44-year-old pregnancies. Okay, we're not looking at those at all. We just said we'll look at these ones that are unusual for that to happen, because the incident of a pregnancy at that age is highly unusual. Like I said, we had some up to age 60 that fell in that category. So we're looking at those. No, we're not looking at the 30-year-old out there that's have that, unless we do get allegations from time to time, to be fair, that somebody's reporting pregnancy and they're not. We have a 42-year-old under investigation right now that is reported pregnant, and she was not, because she had a tubal ligation done 3 years before that was paid for by Medicaid. So we do get those. But this is a situation where our audit was looking at the pregnant woman program, and we noticed this anomaly because there was a lack of claims for any kind of visit.
Yes.
Thank you, Mr. Chair. I think I appreciate that answer. I do think, though, we need to be really careful about how we're talking about this, because we are talking about an extremely low number of cases relative to the program as a whole, and the unintended consequences of women being deterred from seeking prenatal care are significant. Thank you.
I appreciate your feedback. Thank you.
Thank you, Representative Steen.
Thank you, Mr. Chair, and thank you, Mr. Anderson, for being here today. Just to follow up on a couple things. First, about the pregnancy, do they sign like some kind of a consent or medical release? Because I know there's HIPAA laws and all that, so I was just curious how that works.
We do not require that. We are a healthcare oversight agency, so we are immune to HIPAA. And because of them being a Medicaid recipient, that gives us access to those records.
Okay.
As long as we're doing a criminal investigation.
Okay, thank you. I just was curious about that. And then the second question I had really quick, if that's okay, Mr. Chair, was when you were talking about the WIC and SNAP programs, does that kind of automatically come along with some of that when if they're pregnant and they have those Medicaid issues, or is that a separate program, obviously, that they then apply for in conjunction with that?
It's in conjunction because they're already approved on Medicaid. It makes it the pathway to getting on those other programs simpler.
Okay, thank you.
Thank you. Just a quick follow-up to Representative Weichel. Do you know, compared to other states, what our percentage of geriatric or non-pregnant applicants is? Is that knowledge, or do you? And I'm also concerned because she brought up the fact that some pregnant patients may not be seeking care. I guess you may not know, but I would be interested in knowing how we compare to other states and whether there are a significant number of women not seeking care, but maybe that's for another day.
We're working, as part of our audit, we are working on some of that kind of data. They'll be in our report when we do publish it.
Okay. Representative Bueller.
Thank you, Mr. Vice Chair, and thank you, Stephen, for being here. I'm placing this issue in context of some of the other things that we've been collectively working on, like SNAP error rates and those kind of things. So, and I think the chair touched on this a little bit. Has KDHE seen this information that we're reviewing today, this $798,000?
They're aware of it.
Okay.
This is not the first time I've talked about this in front of other committees, so they're well aware of it.
So that kind of gets to my point. How long have they known about it? And I don't think we, either in this committee or in Bethel, have heard a response from KDHE in terms of what they're going to do about it. So am I tracking that correctly?
They have not been given a formal report to respond to at this point.
Okay, so they don't have a formal report?
That's
Okay.
right. That's right.
All right.
They will be getting a interim report shortly.
Okay. All right. Thank you, Stephen. And maybe just a comment to the chair. I do think this is, whether it's relevant tomorrow in the Bethel Committee, but yeah, I would think an agency, once they knew of something like this, would at least investigate their process. I am very respectful of the people that we're serving, but we're taking a portion of federal money and Kansas money, and there's almost $1 million that appears to be going to people who don't deserve it. So, and that to me, as a process owner, and I know I'm preaching to the choir, KDHE as the process owner should be actively looking to make their process better. So thank you, Mr. Vice.
Thank you. Representative Turner.
Thank you, Mr. Chair. Thank you for being here, and thanks for your work. So my question is really a follow-up to Representative Carpenter's question. So he asked, what's the solution? And you said, it could be the caseworkers verifying and seeing if they've had wellness checks. That's not statute stuff. So is that internal to the agency, or is that something that we in the legislature have access to? Thank you.
Sure. Like I said, the federal regulation or guideline says that they have to take self-attestation unless there's information that's contrary, which leads us to believe that they could potentially ask a question if they wanted to, but they choose not to. The internal guidance that KDHE gives to its eligibility workers is they don't ask questions. And that comes from a couple of people we've talked to and people that have inside knowledge that they're basically told, just move along, you don't have a lot of time. Because, the eligibility workers are on a call clock and they have to hurry along. They don't have time to dally with individuals, so they just move along. And we saw no evidence in any of the files we looked at, because they put notes in the file whenever they have communication with anybody. And there was never any indication that they asked the person about their pregnancy or do you have any proof that you're pregnant. There's no indication that ever occurred or getting additional information.
Okay, so these are guidelines within the department?
Yes.
All right, thank you.
Representative Rees.
Thank you. Good to see you again. With KDHE, those are CMS regulations that they don't have to ask the question unless they have some suspicion.
Correct.
Okay, so KDHE is following a CMS rule by not asking.
That's right.
Right, okay, thank you.
Representative Howell.
Thank you, Chair. So just kind of following along with that same thinking, and I'm parsing words just a little bit here, but they matter. So is it that they don't have to ask or they are not allowed to ask?
They are discouraged from asking by internal regulation. The CMS guidelines allows them to ask if they have reason to believe there's contrary information. However, the internal guidance that they're given by KDHE leadership is don't ask, and they're not encouraged to. In fact, they're discouraged from asking those questions. And like I said, of the files we looked at those, there was not a single incident where they asked the question.
Okay, and if I may, and then, and I may be rephrasing a previous question of Representative Bryce, but do we know out of all these cases, how many of these women were not seeking prenatal care?
That's the point. These 62 never had a single prenatal visit.
None of them.
That's
okay,
right.
I just want to make sure I had that straight.
There were
Okay,
certainly others that did, and they appear to be legitimate. So of the 151 people that were 45 and older, these 62 had no care, nothing happened.
So that's very concerning considering these are geriatric pregnancies.
Yes.
And so that would be considered high risk for both the mother and the child. So, I mean, that's just very concerning. And, I mean, that's what our tax dollars are paying for, is for them to receive care. So I find this very troubling.
Representative Berquist.
Thank you, Mr. Vice Chair. Thank you for your presentation again. We heard a report from you last year, similar, but not quite as large numbers, and wanted to know some of the impairment you saw back then to being able to find more information was that you were short on staff to be able to do that. The funding request was made by you, and I believe the chair may be referring to that now. Is there monies that we know of that are assigned to this task that are just not being released?
That's in front of my testimony. I talked about the fact that we had been approved for 9 additional FTEs, and the FTEs were approved. However, the funding didn't go along with that, so we're still waiting on the funding to be approved for those 9 FTEs, which allows us to make those hires.
Thank you, Mr. Chair. One more then. So we don't know of more situations and more likely fraud, but we haven't got the staff to be able to look further to do that. I'll defer back to our chair and to his request for his idea of a proviso, and I appreciate your time and I appreciate your comment, Mr. Chair.
Representative Rivas.
Yeah, thanks for your report. It's very concerning. My question is, do you plan a future audit to maybe, my example is the one that you talked about who had tubal ligation yet claimed to be pregnant. Is there a process where you could screen through other people in this program to at least rule out obvious, glaring fraud like that versus, I mean, not making a witch hunt, but just have a way to at least locate those?
Sure. No, that we have the ability to do data analytics on part of the process, and we certainly intend to do that. There's software that I know that the legislature is considering that looks for anomalies in processes. That may be a capability would help us find things like that a little simpler. I have very talented analysts on my staff, but there's only so much they can do in a given day. And but yes, we're able to go in and go through the data and look at the claims and the billings to see if there are claims for certain things. And even for people that fall in the normal age category, if you will, we would still want to see, are they getting or do they have claims for that are pregnancy-related claims? So that is, yes, that is a possibility. We do not currently have an audit planned to look at that. Our audit that is ongoing is looking at the program in its totality right now, but we are not at the stage where we have finished the report up and are ready to put out final findings and recommendations yet.
Representative McDonald.
I'm trying to figure out the best way to say this in a respectful and tactful way, and I do have respect for you, sir, but last year when you were here, I was personally pretty concerned about our hyperfixation on women in particular, and in the scope of the things that you work on, it is disturbing to me that this group of people has spent this much time talking about 64 women who might have been pregnant. Tubal ligations do fail. I've been a geriatric parent, advanced maternal age. Like, women in pregnancy, it's a very personal thing. And if we start down a slippery slope of requiring people to take tests to prove it, do we make them take the test every month? Because pregnancies also fail. I do appreciate that we are trying to make sure that the resources we allocate go to the people that we need. And I may be hypersensitive to the focus on women, but I would have hoped you could have talked to us more about some bigger fish that you were after, that like you promised us last year.
Well, further in my presentation, I might satisfy your issue. I also want to share with you that on the SNAP side of things, they do ask for proof of pregnancy. That's how we find out about some of these, is when the person provides the proof that turns out to be false. So the SNAP folks do ask for proof of pregnancy. It's Medicaid that does not.
I guess in response, I would just say access to health care is not as readily accessible to all as maybe those of us with privilege assume.
Okay, no other questions. Go ahead, Mr. Anderson.
Thank you, sir. Next issue on my presentation is talking about pharmacy dispensing fees. That's an ongoing audit. We don't have any preliminary results on that, but that is basically the issue of pharmacists who write scripts for over-the-counter medications who go to somebody and then they go and fill them. What we didn't know until we started looking at this is there's a dispensing fee that the pharmacy gets. It's a $10.50 dispensing fee. So you have a situation where a doctor writes a script for, let's say, ibuprofen or some over-the-counter med that's not all that expensive. The person goes and fills it. They get the script filled. The pharmacist they bill Medicaid, but they also get a $10.50 dispensing fee. So we're just looking to see, one is, does the dispensing fee actually go to the pharmacist? We're understanding in some cases the PBMs are intercepting part of that money. That's the pharmacy benefit managers. We're also wanting to understand, why is that happening? Why are we giving scripts to folks so they can get a $2 or $3 bottle of pills that's over the counter that they could pay for? And I get it that the doctor is trying to help the Medicaid beneficiary out by doing that, but it's causing additional cost for the agency, and maybe there's a better way to look at it. So we're looking at that in totality to see what the situation is. If there's no questions on that, I'll move on to the next issue. Okay. The HCBS 2 audit, that is a follow-up audit to an audit that we completed on home and community-based services back in 2022, where we found that there were literally thousands of people who were not using Medicaid waiver services and should have been removed from the program. We reported back then, I think it was $193 million in wasted payments and capitation that went to the MCOs for people who should have been removed from services. Well, this time we were more looking at the functional assessments that are supposed to be done. And what we found was that there were an awful lot of people who did not have functional assessments. You're required by federal and state rules to have a functional assessment done yearly to stay on the waiver. And we found that a lot of these waivers or these functional assessments were not being done. In fact, it resulted in quite a few people, and we estimated the savings on that could be $36 million a year. Now, I'm not saying take them off Medicaid, be clear. If they've removed from off the waiver onto regular Medicaid, they've still have Medicaid coverage, assuming they were financially eligible at that point, the state would save $36 million by doing that. And that comes a lot because of the significant cost difference between somebody that's on a waiver and somebody who's on regular Medicaid. The physically disabled waiver, the average capitation is over $5,000 per month for somebody who's on that waiver. Whereas the average Medicaid for somebody who's on regular Medicaid is only around $800 a month. So that you see there's a substantial difference in cost. And a lot of the people who are not getting those functional assessments done is because they've either moved, they're non-contactable, they won't come in for the functional assessment. Those are some of the issues why they're not having those functional assessments completed. We found that there were a lot of people that went for as long as 814 days without assessments. We also found that there were 721 people that went from 4 or more years without having an assessment done. Now, if they're supposed to have an annual assessment, how is it they went for more than 4 years without having an assessment? But yet they were still on coverage, they were still on the waiver. The number of people, and I was talking about the PD waiver, there were out of the 7,881 people that are on, at the time of our audit, that were on the waiver, there were 2,749 who had not had a functional assessment done timely and could have been removed from the waiver and dropped to regular Medicaid services. The primary reason for people not having is just the lack of showing up. They were not reachable. Some of the MCOs that we interviewed reported that some people say, I don't want waiver services anymore. And they will submit a closeout form from the MCO to KDADS saying this person doesn't want a waiver, please remove them from the system, and then those never get processed. So the person stays on it for a continued period of time. So there are attempts to remove them by the MCOs actually, but the forms don't get processed by the state agencies that are supposed to remove them.
Okay, you ready for a question? Representative Weichel?
Thank you, Mr. Chairman. I 100% wholeheartedly agree that if somebody is on HCBS services and they don't need them or they're not accessing those services for some reason, that they should be on, quote, regular Medicaid. Can you explain to me what the eligibility criteria is in Kansas for regular Medicaid?
Well, it's an interesting situation. Obviously, it's financial, but also for so-called regular Medicaid, you have to be medically needy. But also, if you're on caretaker medical, you have to have a dependent. As we know, somebody who's, let's say, a able-bodied 25-year-old with no dependents would not be able to be on Medicaid. But somebody who is disabled or has, they meet the poverty level cut off, and I don't know what that is off the top of my head, but if they meet that and they have a dependent at home, they would qualify for caretaker medical.
Right. The key being there that they have to have a dependent at home and fall under the poverty threshold guidelines, which I think if you're talking about a single parent with one child, I think we're talking in the neighborhood of $400 a month in income. We're talking about very little income. Outside of that, if you don't have disability, right, federally recognized disability, you are not eligible for Medicaid in Kansas. So isn't it very likely there are people who are on HCBS services who would prefer to be in, let's say, a Medicaid expansion category, and where the state would draw down 90% federal dollars to fund their care instead of us paying for HCBS services?
Well, I'm not here to debate that situation, whether or not expansion is a good idea or not. I'm just reporting on what we're finding.
Representative Steens.
Thank you, Mr. Chair. Mr. Anderson, I have a question. So I have a friend whose husband is on the frail and elderly, for instance. And so I guess my question is, so she's had problems before with the case managers or social workers, whoever comes to do the assessments. A lot of times somebody may get switched, or they don't file the paperwork on time, or, there's just lots of things that can happen, right, when you're sending people out to do these assessments, because she has a husband who is totally dependent at home that she cares for, and he is above the age of 65. And so my question is when you're doing these investigations, do you see that it's more something like that, where there's a lot of, maybe there's not enough people doing these assessments at times, or perhaps there's just more error, like you said, the MCOs are reporting, these kinds of fraud things going on. But I'm just curious. I'm not sure how to frame that question, but is it more of a person, like there's just not enough people out there doing these assessments, or if it's more on the other side of that?
It's really a mixed bag. There is a staffing shortage and constant turnover in that arena for the state, for the people who do it, because the contractors that they hire to do that, and we only looked at 3 of the 7 waivers so far. We're going to look at the other 4 before this is over with. But these 3 were all under the ADRCs, and the AAAs who were doing those have been replaced, and now Maximus is the contractor that's doing those. So hopefully they're bringing some things up. One of the things we'd pointed to in our work is that the system that KDEDS uses to track functional assessments is called the KMIS system. We'd reported on it back in 2022 that it was flawed and needed to be updated. To date, they have not done a thing to improve that. In fact, it was on the Bethel watch list for a while about needing to be updated, and they never did anything with it. So that system allows people, and the problem with the system is if somebody comes up, hey, you're eligible for your functional assessment, it never sends out another reminder. If you miss that one tickler, then it's gone. But they have fallout reports that are available to them, and they're aware of it. They had a list of people that hadn't had functional assessments, but they didn't do anything apparently overtly to get that situation corrected. So you have that issue, but then you also have people that move. They don't leave a forwarding address. They don't leave a forwarding phone number. They're hard to reach, or they won't answer the phone because they don't recognize the number. I don't know about you, but if I don't recognize the number, I won't answer it. Well, that's the same situation. So you have somebody who's suspicious, and so they won't answer numbers they don't know about. The MCOs are actually reporting now that they actually help the state find people who are their beneficiaries and try to connect the dots and try to do a little better job of that. I don't know if that answers your question.
Yeah, no, it does. I'm curious because I had another lady, same situation. She was supposed to get a PD waiver, and then she was supposed to be labeled crisis, and nobody came out there. And so there's just a lot of things that are floating around in my head, and I hear these situations, a lot of gaps, and I'm just trying to figure out a solution, like we talked about, how do we fix some of these things? And I think there's still going to be gaps, and people are going to fall through those gaps, even if we perfected it. But thank you.
Yeah.
Representative Carpenter.
Thank you, Mr. Chair. So, Steve, but the MCOs do an annual assessment also, correct?
They do an annual assessment as well.
Okay.
That's more in-depth.
So I'm just saying, I get it that the ADRCs, and of course, they're replaced, and now we have Maximus doing that, but these folks also have had an annual assessment by the MCOs. Is that accurate?
It's not 100%. Even some of them, the MCOs did not get done timely either.
But were they a year late, or were they
We're still evaluating that information.
3 months late, or whatever?
Yeah,
But
we're
I know
still-
they're required to do that, so.
Yes, yeah, they are. And, one of the suggestions is just food for thought that that had come up, and I've had a few people express this, is that the average waiver recipient gets their functional assessment by the state, then they get the further, more in-depth assessment, if done timely, from the MCO. Is the recipients complain about the constant assessments. And it's like, is there a way that we could combine those two assessments and do it at once, rather than having, 1 week the state assessor's talking to you, then 2 weeks later, the MCO assessor's coming out and asking you the same questions plus some, if they find them, and doing that. So that's a problem. But no, there are plenty of examples where the MCOs also did not get the assessments done for whatever reason. And like I said, sometimes they notified the state, please remove this person, and it never happened.
Okay. Well, I know we had quite a, discussion over basis when we've moved to MEFI now for the assessment. So, and I don't think anybody likes those assessments very well. Thank you.
Representative McDonald.
Thank you, Mr. Chair. When we talk about people who are on the brain injury waiver, frail and elderly, other waivers, I know there's sometimes some mental compromise. They're maybe not able to make the leap for all the required paperwork and stuff. So of these, let's say 30% of people in your investigation who were on the brain injury waiver that you found to not be, I don't know, what is your word, like being given erroneous payments? What happens to those people? Have they been thrown off?
No, these people's benefits were not cut. They are, I wouldn't call them even being at fault. It's the fault of the state for
Exactly.
not getting the assessment done. And that's the point we're trying to make. The state's tracking, the state's follow-up is flawed. KDADS isn't doing their responsibility. We're not blaming the brain injury patient. Now, and sometimes they move, they don't provide forwarding information, but I will say too, in the KMA system, we found that there's a problem with how the addresses are transmitted between the various programs, so that the assessors have an old address, but in the other systems the state has availability to, they have the correct address. So you have the the assessors trying to go to the old address, the old phone numbers, and they get frustrated, and after 3 attempts, they drop it. So it's not necessarily the fault of the individual or the beneficiary. It's the state that's dropping the ball.
I guess if I could follow up, maybe I take issue with estimated erroneous state payments. Like, I don't know that those were erroneous. I think that might be a misnomer. And I'm glad to hear that you're not throwing people off of the rolls just because a caseworker dropped the ball.
And again, the beneficiary doesn't get the payments. It goes to the MCO. Those payments, those capitation payments, are going to the MCOs. They're not going to the individual at all. I mean, that's one of the misconceptions some people have about Medicaid, is the beneficiary never receives a dime. It's all money that goes to the MCO.
Any other questions? Okay, you can proceed, Mr. Anderson.
The next thing I'd like to talk about is an information brief or an issue brief that we put out involving voter registration. And that was a situation, and that report was published. And it has just to do with what we consider to be waste, because there were voter registration applications were sent out to people. And on the KDHE site, they removed the language that is required by the federal regulation to say you can either check yes or no. If you check no, there's no is a no. But if you leave it blank, that's also considered a no. The state changed it where if you leave it blank, that's considered a yes. And that's the guidance that's given to their employees. They have a memorandum of understanding that was signed with the ACLU and different groups that's how that would be handled going forward. But the problem is they took that language off of their form that's part of their process and removing that information. So, but their guidance, internal guidance to their staff is if somebody leaves it blank, then that's created as a yes, that yes, I do want voter registration. Well, what we found is that a lot of people get multiple voter registration packets per year. And we also have DCF also doing the same thing. So if a person that's on SNAP as well as Medicaid changes their address, both agencies are going to send them a voter registration packet. And we've had people that have got multiple ones in the same year. Every time the address changes, they change their phone number, or they make any contact with them, they automatically get it. And also on their annual recertification, they get voter registration packets, regardless of how they handle that question. And we found that the majority of them, in this case, only 1.16 of them actually said, yes, please send me the packet. The rest of them were either blank or no's. So it's money that's spent that doesn't have to be spent. We got numbers on there that we spent over about $450,000 sending these packets out to people who didn't want them. And it's something that is a way to cut cost and to save some money. And one of the things we didn't calculate in there is the employee cost. This is just the mailing cost that we use based upon a rough estimate that was provided by KDHE. And so consequently, that's money that's out there. But also, what is the employee cost of putting this together and mailing these things? And it's not a huge amount of money, but yet it's a way to save some money. So that's why this is an issue brief. We didn't do a full investigation or a full audit on it, but we did the brief and just wanted to demonstrate this is one of those ways where we could save a little money. And it's the sending these voter registration packets out to people that aren't interested in them. And there have been some slip-ups. We had one incident in the report where we put in there that somebody who had received coverage under SOBRA. And for those of you who don't know, SOBRA is the process that the federal government uses and through Medicaid funds that if a undocumented person is pregnant and goes and has delivery at a hospital, goes for delivery, that's where the hospital gets compensated for the cost of providing the delivery. And that person also got, because then they had address, they got a voter registration packet mistakenly. And part of it's the programming and keys needs to be updated to stop things like that from happening.
Are there any questions? Yes, Representative Meyer.
Thank you, Mr. Chair. Thank you for bringing this up. So I have some questions about this. I serve on the Elections Committee as well, so this is, going to that right after here. So this was done, though, to come back into compliance with the NVRA. What would you suggest, then, that we be doing so that we don't fall out of compliance again? I'm concerned because it sounds like it's being suggested that we no longer send voter registration packets out, and feel free to correct me if I'm wrong about that. But that would be my biggest concern, because this is a new agreement so that we came back into compliance because we formerly were not doing this and it's required. And while I understand that there is a cost associated with sending out packets to people who don't necessarily want them, my biggest concern would be them not having that access or having the education simply so that we can save dollars, which would still then make us fall out of compliance again.
Yeah, I understand they were out of compliance, and you're talking about like 2019, 2020, and they fixed it. And then they entered into that agreement, and then they basically took themselves out of compliance with the federal regulation that clearly says they need to have this language on their form that says if you do not check either box, you will be considered to have decided not to register to vote at this time. And then here's the form that's on KDHE's website. Sorry about that. And it's clearly not on there. It's required by federal regulation to be on there. And this form, or this checkbox, is toward the end of the very long, lengthy application for Medicaid, so a lot of people ignore it. But that very bold language is supposed to be on that form, and they removed it. DCF has it on their form. So it's KDHE that doesn't have it on theirs. So we're just asking, put it on there and obey what the federal guidance say. We don't want, we still want people that want the form, absolutely should be able to get it. That's not the issue. It's just we're asking KDHE to follow the federal regulations. They want to follow regulations on everything else, follow it on this.
Any other questions? Yeah. Okay, Mr. Anderson, do you have anything else?
Just very briefly, want to talk about a few investigation issues that we're dealing with. Just wanted to let you know we have 7 state-level investigations going right now and 2 federal-level investigations have been accepted for prosecution. I want to be key on that they've been accepted for prosecution. We have literally over 100 investigations open, but these have been accepted by a prosecutor to be followed up on. One of them is a federal case where an individual assumed the identity of a deceased cousin so they could qualify for Social Security benefits under both identities, as well as get Medicaid coverage. And they ended up being caught when they showed up at a Social Security office with 2 separate appointments. One where her identity she was using, she was disabled, so she showed up in a wheelchair. The next day she showed up at a different Social Security office. She walked right in. But the only problem was there was a Social Security OIG agent at both locations who greeted her and kind of blew the whole thing up. And she was married under her dead cousin's identity, which would have rendered her ineligible for SSI, Social Security Supplemental Income. So consequently, that also got her on Medicaid because of the way the system works. She got over $200,000 worth of capitation benefits paid to the MCOs on her behalf. So anyway, she has pled guilty. She's supposed to be sentenced next month. And the restitution amount, or the total loss to the state, is over 200 because she also got SNAP and some other benefits. But the total restitution amount is $453,000 that she'll owe back to the federal government for between Social Security and state benefits for her actions by doing that, because she lived under that lie for a long time. We also have 2 investigations open involving child care centers that have been referred to us, and we're currently looking at those. I think the issue that's going on in Minnesota has sparked people to make referrals. And, but we're wanting to test those allegations and putting resources to doing that just to clear those as quick as we can. And that's kind of the issue there. Some of our investigations do involve state employees. We have a few of those going on. And we're looking at providers as well that are billing for services not rendered. So, and just quickly, I'll just touch on 2. The most previous year, we processed over 1,400 complaints. This most recent fiscal or calendar year, we processed 1,580 files. So every year, it just goes up and up and up on the number of referrals we get. We have seen a real surge, and again, I think the Minnesota issue has caused people to be more aware of what is fraud and wanting to report fraud. So we've seen a little bit of an uptick in that area. A lot of our referrals come through the DCF hotline, which is where CanCare sends people to. But we have a lot of private citizens now calling in and referring to us. So with that, I will conclude my testimony. More than happy to answer any other questions that remain.
Committee, any other questions? Representative Turner.
Thank you, Mr. Chair. Just thank you for the presentation. You know, I think the state creates these programs for people most in need. And, you know, there are rules for those programs. And to the extent that the rules aren't followed by some, yet are by others, is an inherent unfairness to those that do play by the rules. So I think this is important work to make sure that, you know, we're being good, responsible custodians of taxpayer money, because this isn't free money. So this program leakage or excess or whatever you want to categorize it as comes out of the taxpayer's pocket. So anyway, you know, I've heard comment that you want the rules to be different, you know, and that's something the legislature can do. But I appreciate your work, and I think it's important. And the numbers on the page are the thing that is the most focus, you know, not necessarily the program, but they all do add up to be fairly significant. So thank you.
Thank you.
Representative Gardner.
Thank you, Mr. Chair, and thank you for your presentation. Just a general question here. You've made mention several times the deficiency of our information transfer systems, and there are multiple programs here under different management systems. Do you have any recommendations to us about, as we go forward, as policymakers, how do we go about coming up with better information gathering and management systems so that it doesn't leave loopholes for things like this occur. We know that there's going to always be people wanting to take advantage of the system, but it appears to me some of it is our system isn't optimally put together.
Yeah, and I'll give you a really good example, sir. These forms that are used by the MCOs to suggest that people be removed are emailed from the MCO to KDHE and KDADS, rather than using a database system or an online. They also send spreadsheets of issues for them. Sometimes they'll have 300 or 400 lines on it, but they're sent to KDHE to manage. The problem is it's a simple spreadsheet. You can easily delete a line on a spreadsheet or change it, or just never, and nothing ever happens. The KMIS system has been a problem for years. We identified it, like I said, in 2022 that it was a problem, and it still persists as a problem. In fact, KDADS at one point had $1 million that it had been earmarked for them to try to find a solution, and they opted not to act on it. So we had recommended that the functionality of the KMIS system be moved into the KEYS system or some other system that currently exists. Yes, there would be a cost in that, but it would at least allow for better tracking, and it would allow that to happen. We have systems out there that the different state agencies will not allow other people on the system that would help them have access to information, but they won't let them on the system. KEYS, for example, KDADS is not allowing people, or KDHE does not allow members from KDADS to be on the KEY system, which would help them understand where the eligibility process is at. And KMIS is a isolated system that only KDADS has access to the KMIS system. Not to say that it would be a great deal to get access to it, but it's basically standalone.
Okay, thank you very much. Thank you, Mr. Chair.
Any other questions from the committee? You have anything? Thank you very much, Mr. Anderson. I appreciate your report. Very informative.
Thank you, committee.
Representative Carpenter.
Thank you, Mr. Chair. So, committee, as many of you know, we're kind of in limbo, waiting on bills and trying to get something to do. And so I just ask for your patience. And we may, I wouldn't want to say spring things on you, but we're looking for bills that are pretty innocuous, pretty easy, you know, to work or to hear and work at the same time. It won't be anything that's controversial that, you know, to spring on you, but just bear with us because we are getting some trickling in. Carly, thank you for that. We are getting some bills trickling in, and I think the week after next we'll be able to go full bore and, you know, work and hear and work and all that. So just, we got one more week that's kind of dicey, and then we're going to get to work, and then you better hang on.
Very good. If there's nothing else, we'll adjourn. Thank you.